Wonderful. So I'm going to talk about how to successfully treat BDD with medication. And here are my disclosures. And first, let me define BDD, which is defined as preoccupation with one or more perceived defects in physical or flaws in physical appearance, which are not observable or appear only slight to others. So people with BDD think they look abnormal in some way, ugly. Some say like a monster. Some use less harsh terms like unattractive. When in reality, the flaws that they perceive are not visible to others. And often these people are actually very attractive people. But in their mind, they look unattractive, ugly, deformed. And they perform repetitive behaviors such as excessive mirror checking, excessive grooming, skin picking, trying to make their skin look better. That's the most common area of concern, is perceived flaws of the skin, reassurance seeking about how they look, or repetitive mental acts, comparing their appearance with that of others in response to the appearance concerns. BDD, to be diagnosed, must cause clinically significant distress or impairment in functioning, and it's not better explained by an eating disorder. So if someone thinks only that they're too fat or that their stomach is too fat, and their symptoms meet diagnostic criteria for an eating disorder, you would diagnose that as an eating disorder, not BDD. But these two disorders can co-occur. So for example, someone may think they're too fat or their stomach's too big and have an eating disorder, but also be obsessed with perceived scarring of their skin, or think that their nose is too big or their hair is falling out, when in fact none of these things are accurate beliefs. And in that case, you would diagnose both disorders. So I want to highlight this criterion C because I think it is required for the diagnosis of BDD, and it does help us differentiate BDD from more normative, common appearance concerns that so much of the population has these days, especially. So what is BDD not? I don't know if I can remove this strip up here. It's a little bit in the way. Okay. So BDD is not, I'm having a little trouble advancing my slides also. So let me see what I have to do here. Okay. It's not vanity. It's certainly not trivial. It's not simply appearance dissatisfaction, and that's where the requirement for significant emotional distress or impairment in functioning is helpful part of the definition of BDD. It's not just an adolescent phase. In fact, BDD most often starts during adolescence. And it's not the same as OCD. I think it often is confused with OCD. There are similarities like the obsessive thoughts and the compulsive behaviors. But numerous studies have shown that BDD tends to be characterized by more depression, more suicidality, poorer insight, so less of an awareness that a person has BDD, more conviction that their belief is true, that they truly are ugly, for example. Probably more substance abuse as well, and a variety of different such as people with BDD often get cosmetic treatment for their perceived deformities, which unfortunately is virtually never helpful. So why should we recognize and treat BDD? Well, it's common. It is actually more common than OCD, than anorexia nervosa, schizophrenia, a variety of other disorders. It currently affects about 2 to 3% of the general population, but it's very under-recognized, and it causes tremendous suffering and impairment in day-to-day functioning. It's associated with very high rates of suicidality, and more studies are coming out suggesting that the rates of suicidal ideation and suicide attempts might be higher in BDD than in any other psychiatric disorder in which suicidality has been studied. That's possibly true. Of course, we still need more data, but it's a very concerning part of BDD. And it's one of the things that makes it so important to recognize and treat this problem. And the good news is it usually improves with the right treatment. We have much less research data on BDD than in OCD. The research on BDD started long after that on OCD. But the treatments that we have now are good. They help the majority of people who get them as long as they're implemented correctly. So my own perspective is for milder BDD, we often want to start with CBT. It does need to be tailored to BDD's unique features. Some of the characteristics of CBT overlap with those of OCD, and some features are different. So we do, cognitive restructuring, and we'll do some exposure and ritual prevention, but we also need to do some perceptual retraining and address desire for or receipt of cosmetic treatment, etc. There are some differences, and the poor insight does need to be addressed in treatment as well when we're treating BDD. But medication is also reasonable for mild BDD, especially if there's comorbidity that may improve with medication, co-occurring major depressive disorder or OCD or social anxiety disorder, because one medication may treat all of these conditions simultaneously if CBT isn't available or if the patient prefers medication. For more moderate BDD, I would say medication and or CBT. And for severe BDD, I always recommend both. And I would say you always need medication if there are concerning levels of suicidality. And we often have to consider a higher level of care for more severe BDD. So medication helps most people with BDD. For medication to work, you need the right medication, the right dose, a long enough trial, good adherence, and unfortunately though, most medication trials for BDD are not adequate. Most people do not get all of these. So the first line medication for BDD, I'm sure Dr. Corinne spoke about this, is SRIs. They're our first line medication for many disorders, in psychiatric disorders. They're often effective. They often decrease BDD obsessions and repetitive behaviors, distress, depression, anger, irritability, anxiety. They often improve insight, so people begin to realize that they actually look normal. They do not look abnormal in any way. Functioning often improves, quality of life. They're usually well tolerated. And they're also often effective for many other conditions and are our first line medication for OCD, as I'm sure you heard today, depression, binge eating disorder, bulimia, anxiety disorders, etc. So very commonly used, not addictive, not habit forming, very uncommon for people not to be able to take them because of side effects. That's unusual. So I usually prescribe one of these. I mean, they're probably all equally effective, but I like these three, based on having treated BDD for many, many decades. We also have fluvoxamine. Clomipramine is a good option if several of the above haven't worked. In BDD, we don't have nice head-to-head comparisons of these meds with one another as we do in OCD, but they're probably all equally effective as in OCD. But clomipramine, it's a little different from the SSRIs, and it is a good option if one of the SSRIs haven't worked. It might be a little more likely to cause some side effects, so we usually don't start with it, but most people tolerate it well. There's also paroxetine, and citalopram I don't use anymore because the FDA more recently put what I consider a pretty firm dosing limit that is typically too low to successfully treat BDD. So these are SRIs are the first line medication for both delusional and non-delusional and delusional BDD. So this is BDD with complete conviction that the person looks abnormal. And I want to emphasize this because for other psychiatric disorders, if someone has an inaccurate belief that they firmly hold on to, we typically think of using an antipsychotic medication. But study after study in BDD has shown that SRIs alone work just as well if someone is completely convinced that they look abnormal or completely certain that they don't have BDD, they just need cosmetic surgery. This is less of an issue in OCD because insight tends to be much better in OCD. But it's probably also the case that SRIs alone work for delusional forms of OCD. So when we didn't know how to treat BDD, a couple of us just started treating patients. This was back in the 1980s, early 90s, and tried different things. And we're kind of finding among our patients that SRIs were more effective than other medications. And that made sense because SRIs, we knew were effective for OCD. BDD has many features in common with OCD. This led to some nice, rigorous open label treatment trials with high response rates. If you do analyses with only the patients who completed the trial, you don't include the dropouts, for example, the response rates are even higher than these. And then some controlled trials were done comparing an SRI to a non-SRI medication or to placebo, showing that the SRIs are more effective. So here's my usual first-line approach. My usual first-line approach is to start with an SSRI based on the data that we have. I try to reach the maximum FDA dose, but 30 milligrams for Lexapro, because that maximum FDA dose for Lexapro is low relative to the other SRIs. And I usually try to get there within 5 to 10 weeks if the medication is tolerated well enough, which it usually is, and if a lower dose isn't working. So if a lower dose is working, you don't have to keep raising the dose. You can hold it at the lower dose and just give it more time and see if that will eventually work. Clomipramine dosing is guided by blood levels, and you need to check EKGs. With younger youth and with elderly, we typically start with a lower dose, raise the dose more slowly, and may not reach as high a dose. And we do a total trial duration of 12, maybe 14 weeks to figure out if a person's going to be a responder to the medication, with about 4 of these weeks on the maximum FDA dose, if the person needs that high dose, with good adherence. That's very, very important to take it every day. So this will often work for a majority of people. But what if an SSRI doesn't help well enough? What do you do next? The first thing is to make sure it was taken every day, because if you miss any doses, it may not work for you. We do not have any research data on which of these is the next best choice. We don't actually know. So I'm just going to share my view with you. My first approach is to increase the SSRI dose. That's the easiest thing to do, and it often works. So this slide shows SRI dosing for BDD. Here are the FDA maximum doses. Now, they are not written in stone, and you can exceed them for 5 of these 7 medications. I personally don't exceed for clomipramine, and once the FDA lowered the maximum dose for citalopram, I considered a bit of a firmer dosing limit. I don't exceed it anymore. I don't use it anymore. Here you can see the maximum doses that we use for BDD, and they just happen to be the same doses in the AP, the American Psychiatric Association practice guideline for OCD, for occasionally prescribed maximum doses. Here you see my average doses. We don't have any nice dose finding studies in BDD where people are randomized to, 20 versus 40 versus 60 of fluoxetine. I think the only data on dose that we have is from my clinical practice, which you see on this slide. And you can see that my average doses, and these are standard deviations here, so my average doses are, sometimes at the FDA max, or even over. This is what I used to use for Celexa. I don't prescribe it anymore, because you can see this is much higher than the current fairly firm maximum dose, which changed over time. I think you can also, you also need to get EKGs with clomipramine. You can with high SSRI doses. And for escitalopram, for Lexapro, I usually get an EKG at 40 milligrams a day and then higher, although I can't recall ever seeing a problem with the EKG on these higher doses. You can then augment. If this doesn't work, you can add another medication to the SRI. And similar to OCD, I think we are increasingly using antipsychotics, neuroleptics. This is a bit of a misnomer. It is true that these medications are good for psychosis, but they treat a whole broad range of symptoms. And as you probably heard from Dr. Curran, they're often used in OCD, a first-line add-on medication. I did a study many years ago of Pimozide. This is an older, so-called typical or first-generation neuroleptic, which actually didn't work for BDD, although there's a positive study in OCD. There's some chart review studies with kind of equivocal results. It's a little hard to sort out the data because patients were not uncommonly getting multiple types of treatment at the same time, but some suggested that antipsychotics or neuroleptics were effective. But I think increasingly clinical experience and expert consensus suggests efficacy for atypicals, the newer second generation neuroleptics. I especially prefer aripiprazole. And usually we wait for the full SRI trial to be done and then see if there are remaining symptoms and then consider adding a medicine like this. But sometimes I add it at the beginning of treatment or before an SRI trial is adequate, especially if patients have very severe depression, suicidality, hostility, aggression, agitation. Sometimes we see these characteristics in OCD. I think you see them more often in BDD. So sometimes I don't wait for a full SRI trial before adding one of these meds. Buspirone, this is a non-habit forming, non-addicting, very well-tolerated anti-anxiety medicine. I published some data years ago suggesting that maybe 30 to 40% of people will improve if you add buspirone to an SRI. And then glutamate modulators, which you probably heard about from Dr. Coran. No data in BDD, but in my clinical experience, N-acetylcysteine, NAC, at these doses, and memantine, and sometimes I'll use higher doses of memantine, can be quite helpful for BDD and for OCD, and are usually very well tolerated. So that's an advantage of these, of the glutamate modulators. If this doesn't work, you can switch to another SSRI or the SRI clomipramine, and works in close to half the time, but higher if you add in augmentation strategies. If several SSRIs haven't helped, try the SRI clomipramine. And then you can consider these medications. These are all serotonergic, serotonin-boosting medications. There's one small trial of venlafaxine, Effexor in BDD, showing a signal of efficacy. I do think these medications can be helpful, but they are not first line because we don't have as much data. And in my clinical experience, I don't think they're quite as good as the SSRIs. And just remember, with side effects, I think, I often hear people don't want to try these medications because of side effects, but most people get none. It's often hard to figure out if a physical symptom is actually a side effect. It might be it, but it might not be. And you can start the medication at a lower dose than usual. That can make a big difference. There have been times when I've started escitalopram, Lexapro, 1 milligram a day instead of the usual 10 milligrams a day, and that's enabled people to tolerate it. If side effects occur, they're often tolerable and often get better with time. If not, certain remedies can help. And don't let fear of side effects prevent you from getting well. And what I often suggest to people is just give the medication a good try, and after you have a good trial, decide at that point what are the pros and cons for you as an individual, and then decide what you want to do as a next step. And we don't know if these treatments work for BDD. There are no published research studies, but hopefully there will be in the near future. On the other hand, medication and CBT work well for most people with BDD if they're well implemented. So in summary, BDD is common, it's under-recognized, it's often severe. Most people substantially improve with the right medication. It can be life-saving. SRIs, often at high doses of the first-line medication, but certain other medications can also help. And it's important to take the right medication at the right dose every day for long enough time to give it a good try. So thank you so much.